Hello everyone, this is the EMT 200 Orthopedic Injury Overview. And these are some of the more common reasons that an ambulance is called. And these can also be distracting injuries that may not be the most serious ones that a patient has. We always want to look for multi-system trauma. So we're going to talk about the mechanism of injuries. We're going to talk about the different types of musculoskeletal injuries and the treatment for them and the special considerations that some areas with the musculoskeletal system have. So first, there's a few different mechanisms of injury for musculoskeletal injuries. Most of us have probably had at least one of these at some point. And there's the direct blow, blunt trauma at the point of impact. So this would be someone strikes your arm with a blunt object, and there's a fracture at that point where it was struck. There's also an indirect force that causes a fracture at a distal point. So when I was 5 and I fell off of a swing set, I outstretched my arm, and my hand made contact with the ground, but I had a fracture upper of my radius and my ulna. So that was an indirect force, and the injury was at a point different from the point of impact. There can also be twisting injuries. We see these with athletes with the ligaments at their joints. And then there's high-energy injuries, like with a high-speed crash, where the skeleton the bones can pierce soft tissues and damage vital internal organs. And with children, the ribs and their musculoskeletal system is less pliable. So the ribs actually offer less protection to their internal organs. And as we get older, geriatric patients have a calcified, rigid skeleton, and their bones actually provide them more protection to their internal organs if they're in the setting of a multi-system trauma. Fractures can also be a sign of abuse and neglect. So that's something else that we want to be careful of and assess for. Okay, so the most common type of musculoskeletal injury we encounter is the fracture. This is the break in the continuity of the bone. Fractures can be open or closed, and they can be complete or incomplete. An open fracture, there's an external wound, and bones may be piercing through the skin, and there's an opportunity for external bleeding, and then there's an opportunity for infection there. Closed fractures remain inside the body, and those can be complete, where there's a complete fracture throughout the bone, or incomplete, where there's a hairline fracture that does not penetrate through the entire section of bone. And there's also displaced and non-displaced. So with displaced, the bones are completely separated from each other. There's no longer the bones no longer have a continuity. Non-displaced, the bones are still together. There's just a crack that's through that. A displaced fracture may cause visible deformity. If there's a visible deformity, or they call it a false joint, where the bone is moving as if a joint would, those would be considered displaced. Some other ones, there's a spiral fracture. That's if there's a twisting force that can cause like a crack up of the bone. And the sign of a fracture is that the DCAT BTLS mnemonic is we're looking for a deformity, crepitus, which is scraping of the bone ends together, tenderness, which is pain on palpation, guarding, the patient doesn't want to move it. We're looking for swelling, although we might not see as much if it's initially. But we're also looking for bruising. We talked about false motion. There might be fragments exposed, and if a joint may actually be locked too. So those are fractures, and in a minute we're going to get into some management for some of the specific types. Dislocation is where the bone ends in a joint no longer connect, and a lot of times there's a ligament. The ligaments is what hold the bones together at joints, and those can be torn as well. There's a fracture and a dislocation from high mechanisms can also occur. You can have both. And the signs, the treatment for a dislocation and the signs and symptoms are very similar. is for a fracture. And sprains are a pain at a twisted joint with an injury to the ligaments. So sprain is injury to the ligaments. It's very difficult to tell the difference between a sprain and a fracture. We're going to transport to the hospital, or maybe if you have a protocol for an urgent care or something, you're going to they would need an x-ray to identify that. The treatment for a sprain is the same as for a fracture or dislocation. A strain involves tendons. Tendons are on long bone joints, and same thing. It's something they're going to be assessed for a fracture. We're going to assume that it's a fracture. An amputation is where the part of the extremity is completely severed from the body, and this can be complete or incomplete, and so that maybe part of the arm or maybe hanging by skin or by some tendons, or maybe completely displaced from the body. And so when we're assessing a patient with musculoskeletal injuries, again, we want to look for signs of multi-system trauma. We're looking for signs of shock. We're looking for multiple injuries or altered mental status. And if that's the case, we're going to initiate rapid transport. This may be one of the times we use a backboard, because the backboard can be the universal splint. It'll provide some protection to the fractured joints. And after we manage everything else, if there's still time before we get to the hospital, then we could work on caring for the fractures. Fortunately, most of these calls that we calls to EMS are not critical patients, and the fracture is isolated. And if that's the case, after we do a trauma assessment, if we can rule out life threats to the best of our ability to assess patients, then we can take a little more time on scene, splint the patient before moving. If you think about how painful it's going to be if the bone or the injury is aggravated during movement, and then they're going to be bouncing up and down the road on the way to the hospital, we want to do as much as we can before moving the patient to minimize the pain, minimize the secondary damage that movement could cause. So the way that we're going to manage musculoskeletal injuries is a splint. Splint helps make the minimize movement and aggravate the limb with the injury. This might provide some pain relief. You can also give some ice. And if you're a paramedic unit or you have a paramedic unit coming, they could give some pain medicine as well before moving the patient. So we want to manage external bleeding. So if there's a fracture with major bleeding, the bleeding is the bigger life threat. If there's a situation where there's a open fracture and major bleeding, that may be a time we have to go right to a tourniquet, because we're not going to be able to hold direct pressure onto that site where the bones are outside the skin. So we may need to put a tourniquet above there. But we would worry about that before worrying about the fracture. So when we're using the splint, even if there is no external bleeding, if the fracture is open, we want to address the bleed by putting a dry, sterile dressing on to try to prevent infection. And we generally want to stabilize the injuries, whether it's a bone or a dislocation, in the position where it is. We're going to assess for neurologic or neurovascular status. We're going to check for a pulse distal to the injury. We're going to check for motion, ask the patient to move their hands or their toes. And we're going to ask them to squeeze your hand. Ask which finger you're touching or which toe you're touching. So ask them what they feel. So we want to check that and provide manual stabilization before we attempt to splint or continue our assessment. So we're going to do that before we apply a splint or manipulate a bone, and we're going to check that after. So the patient does not have a pulse. So the pulse, that means blood is cut off to that extremity. That is a threat to limb. We're going to gently apply traction and try to move it back into place. And that's only if we don't have a pulse. Pretty much everything else we're going to splint. Try to splint in the position found. If there's a false joint where an extremity is moving freely, then we would try to place that in the neutral inline position. So the principles of splinting is to Our goal is to stabilize the joint above and below where the injury is. And if it's a joint, we want to stabilize the bones on either side of the joint so they don't move. And when we go to the long bone, if it's a forearm injury, we would want to stabilize the elbow and the wrist so the patient can't move their elbow or the wrist. And so we're going to apply the rigid splint or a SAM splint. There's a number of different splinting devices that we'll get into in lab. And you want to position the hand in the position of function. So you want to put a roll of cling or a triangular bandage or something to keep their hand in place. We would place the splint around the elbow and the wrist, and then to keep the elbow secure, we would apply a sling and a swath to keep that up against the patient's body and to prevent that from moving or limit its movement. For injuries in the shoulder, the scapula, the clavicle, we're going to treat those as with a sling and a swath. So all three of those, we would use a triangular bandage, then secure the injury. Use a triangular bandage to keep the arm and keep the bones on either side of the joint in position, and then secure that to the rest of the body. So same thing with the if there's an injury to the tibia or fibula, the lower leg, we would keep the foot in a forward position using some splinting techniques, and then we want to stabilize the knee so the patient would have limited movement of the knee and their foot. And after we splint, we would always check for pulse, motor, and neurovascular status after we document both. So a few special bones that we're going to talk about is the proximal femur, and this is also called a hip fracture. Most of the time, you may even take someone to the hospital, call it a hip fracture. And it's technically not the hip. The hip is a joint. And it's actually the proximal femur, the very tip of the femur where it turns, and that's what fractures. And this can happen spontaneously. Patients can be walking. People with osteoporosis are at risk for this. It may actually cause a fall. And the sign of a proximal femur injury is the leg will be shortened and rotated outwards. And our treatment for that is if you have pain medicine to give it to them before moving them. But we want to splint the leg in the place where we found it. We don't want to apply manipulation. This is different from a pelvic fracture. Pelvic fractures are caused by a high mechanism of injury. Those come with a high, can cause internal bleeding, and that's what we have the pelvic binder for. A pelvic fracture, even though it's in the same region, a pelvic fracture is different from a proximal femur fracture. The femur fracture patients are usually hemodynamically stable. We just want to splint it in place. The pelvic fracture, that is a life threat. We need to bind the pelvis. A pelvic binder is not indicated for a hip fracture or a proximal femur fracture. So moving down to the femoral shaft, so the femur is the strongest bone in the body, and it takes a significant mechanism to break it. A lot of times the patient will have something else more serious wrong with them. But what makes the femur different is it can bleed a lot. So it can cause significant internal bleeding inside the thigh. So we do want to address that with a traction splint. A sign of a midshaft femur fracture is that the bone will be shorter than the non-injured leg, even though it may not be rotated outward. We would use one of the two. We have two devices. There's a few others out to apply traction to try to realign the injured, realign the bones of the femur, and limit blood loss. Again, if the patient has other injuries, this might be something we do during transport or something that we don't have time to do because the focus is to get them off scene and get them to the trauma center. Another type of musculoskeletal injury is the amputation, and one thing is if it is a partial amputation, never complete it. If something is hanging by, there may be a tendon or some skin, we don't want to ever completely complete an amputation. They actually have, if that is necessary, there is a special team of doctors that would come and do that. That would not be us. If there is a finger or an arm or a leg that is completely separated from the patient's body, we want to wrap it up in a moist dressing, place it in a plastic bag, and keep it cool. So put the plastic bag on a cold pack. Don't freeze it. Try not to let it get warm. We want to keep it cool and then take it to the hospital with us. If you have a hospital in your region that specializes in reattachment, then we would want to go there. Again, is that going to kill the patient first? Do they have another injury that's more serious that we need to address and get off scene? So the amputations can be isolated, like injuries with a saw or a snowblower or some lawnmower or something like that. And then, but if there's a significant mechanism of injury where there's a large part of a limb that's missing, the patient may have another more issues wrong with them, and that may not be the most serious one. So the last thing we're going to talk about is compartment syndrome. Compartment syndrome generally happens between 6 and 12 hours after a musculoskeletal injury, and this is from restriction of blood flow to the injured area. This causes toxins to build up. The patient may lose a pulse distal to where the injury is. And the danger is when that gets released into the bloodstream, the toxins that built up can cause heart problems. And so look for edema, swelling, look for a capillary refill, maybe loss of radial pulse distal to where the injury is. The patient may complain of a new type of pain or numbness, and that's an emergency the patient would need. If that's what the patient has, they would need surgery. So go to the hospital that's capable of doing that. So. All right, thank you for listening. That is the musculoskeletal injury overview.